So wanted to welcome everybody and send our best healthy and safe regards to all our Fuld friends and beyond. We've opened this webinar up beyond our traditional Fuld family, hoping that we can share some of this work with as many people as possible, because we've spent a good deal of time trying to look at the evidence related to some topics that we've heard from a lot of you are very pressing. And so in times like these, we wanted to bring our best efforts to this and our evidence-based expertise to give you good guidance rather than just like chaos that's out there. So, so this is the folks you're going to be hearing from today, myself and these other folks from the Fuld team. And these are the topics we're going to talk about. We're going to talk about masks and homemade masks and all things mask. And then we're going to talk about multiple patients being put on a ventilator. What's up with that? And then the other thing is about staffing. And so we have split up into teams and spent the better part of the last week or two really digging deep into the literature and synthesizing the evidence and bringing the best practices forward to you in hopefully very edible bites. And then we have lots of resources on our website and our webpage, which will be, hands-on resources that you can go grab after the webinar. That should be helping with, put it in your hands. The other two topics that we're starting to work on is this whole issue related to proning patients, pre-intubation proning of patients, which we're hearing a lot about. And we're also working on best practices for post-mortem care, both the hospital side, post-mortem, and then and moving patients out and into funeral homes and other out spaces. So those are the things we're working on, but for today we're going to talk to you about these three things. Now we're going to try and keep it brief and concise so that we can leave a chunk of time at the end so that we can answer questions if we haven't addressed them in the actual slides that we have prepared for you. So I'm going to start. We're going to talk about masks first. Myself and next slide, Bindu, myself and my colleague, Dr. Inga Zedinskis. We are the mask team. And then the ventilator sharing was Dr. Penny Gorsuch, Dr. Jennifer Dean, and Laura Weigel Moore. And the ICU staffing was Dr. Molly McNett and Dr. Linda Connor. So that's our teams. And so I feel like we all kind of know a lot about these topics because we've been talking about them so much across groups, but these are the expert panels on each of these. So Inga and myself took a look at homemade cloth face masks. If there was a hot topic on Facebook in the last couple of weeks, it certainly has been making masks. And that's sort of what prompted this whole thing from the Fuld side was, I was on Facebook and everybody was asking me, are they safe? And I was like, gee, I don't know. And then I said to myself, gee, I guess we should write a PICO question. What a great idea. So we wrote the PICO question, and then Inga and I took a deep dive into the literature, and here's what we have for you. We have guidance relative to masks and healthcare workers, and then we have guidance relative to masks and consumers. So I'm going to talk about healthcare workers, and then Inga's going to talk about consumers. So here we go. So we have two groups of people that are looking at the mask concern. We were trying to be very sensitive to using the right graphics here so that when we're talking about all people, we didn't want to show a whole lot of people all clustered together because we should all be physically distancing. Not socially distancing, physically distancing. However, the one on the right for the consumers, we wanted to, kind of show this family together because people are sheltering in space together. So that's why we did show people together. So next slide. So before we really get started with any of the detail about face masks made out of cloth and homemade, we wanted to put forward this very clear statement on behalf of the Fuld that our position on masks is this, that we recommend and support provision of proper PPE for healthcare workers at all points of care, and that healthcare workers should use appropriate PPE consistently and correctly rather than homemade masks. I mean, we are not recommending anybody choose a cloth homemade mask over the proper PPE. And the only PPE that's appropriate for what we're talking about here is the N95s, because they're the only kind of mask that was ever designed to protect the wearer rather than the people on the other side of the wearer. So healthcare workers should consider homemade cloth masks only as our last resort. So that's our overriding statement before we get into anything else. So next slide. Next slide. Okay, so just for a review, there are three kinds of masks that we're going to be talking about. One is the respirator N95 mask, which, you know, I don't have to read you the definition, but just the important piece here is that we all recognize that this is the only kind of mask that is considered PPE. And it filters out about 95% of the particles to the wearer. And that's when they're worn properly and fit properly. So even an N95 respirator can become fairly useless if it doesn't fit. And so that's why we do fit testing and all these other things, because they only work when they fit right. And that, quite frankly, is true. You'll come to find out about any kind of a mask. The next level of masks we're going to talk about are called surgical masks or medical masks. And these are, you know, you've seen a million of these. Well, I guess you wish you'd see a million of these, quite frankly. But these are your surgical masks that we wear in the hospital all the time with kind of the elastic loops that go around your ear. And these were designed and intended to protect people on the other side of the mask from the wearer. So when you wear them in the OR, it's so that the people in the ORs, you know, what they're breathing out doesn't fall into a surgical wound. So they were never designed to protect going in. They were always designed to protect going out. And then there's these cloth homemade face masks, which are also quite loose fitting. And they're made out of a myriad of different kinds of fabrics, different styles, different fashions, different, you name it. So they're sort of a kind of an out of control space, but they can be made in different shapes, etc. But they also are classically loose fitting and widely variable. And they are, again, people wear them to, protect themselves from what's outside, but really they're built to protect, people outside from what's coming out of you. Okay, next slide. Next, okay. So how do these things differentiate? So I kind of talked about that already, but we just wanted to give you some numbers about what the difference in the scientific differences between these types of masks. So an N95 respirator, and this is for adults because it's very different for children, provide 25 times the protection of a surgical or medical mask and 50 times the protection of the average homemade cloth mask. Surgical masks offer about 2 times the protection of a cloth face, homemade mask. And homemade cloth masks provide the wearer with some protection, the range of protection is extraordinarily wide depending on the type of fabric and how it fits and all these other things. So very variable and not terribly protective. Next slide. Okay, so this is just something I want to show you. I know it's not that easy to read on the slide, but if you go to our website, this is an infographic that we've created. The reason I wanted to show it to you here is because this is everything you want to, excuse me, everything you want to know about the differences between masks in an infographic. Basically what we did was we took what the CDC had created for an infographic for both the N95s compared to the surgical mask, and then we added the third column, which is the homemade mask. And so we've created the comparison between the 3 versus just the 2 that the CDC had. So this is a modification of that infographic from the CDC. So you can find this on our website, and it'll give you just a 1-page, quick and clear differentiation between the 3 types that hopefully will be helpful to you. Next slide. Okay, so should healthcare workers wear homemade cloth masks during a pandemic if nothing else is available? And the answer is yes, if nothing else is available. What we found in the literature was healthcare workers who wear a mask or a respirator had had less respiratory infection. But there's multiple things related to that mask that make that protection better or worse. So the thing that matters is, one, how it fits, two, the filtration of the fabric that is in the mask and how many layers and that sort of thing. And then the other thing is how you use the mask properly. So it's fit, filtration, and then following all the rules related to other things you need to be doing. So washing your hands before you put the mask on, and washing your hands before you take the mask off, because every time you touch your hand with your face with your contaminated hands, you're adding to the contamination of the mask. And so the potential, the potential of the mask and the capacity or the ability of the mask is a product of filtration, which is the fabric or the, paper, whatever this is, how well it fits, and how well you adhere to doing what you're supposed to do, which is good hand hygiene, not touching your face, putting it on properly, securing it properly. All those other things together make the biggest difference. So just slapping on, a cloth mask somebody made from home, or putting on one of those surgical masks with those big holes poofing out on the side, is not going to afford you almost any protection whatsoever. So you have to use them properly. The other thing to keep in mind is this McIntyre article, which is being cited quite a bit out on the internet. 2015, and they basically made the case for what, kind of against cloth masks. But it wasn't a pandemic either. But the point that they were making is when these cloth masks or any mask gets moist, that's a problem. So it increases your risk of transmission of particles. So the point is, don't wear a mask once it's moist or damp or wet. So if it does get that way, switch it out and launder it properly. Don't just like lay it on a counter, let it dry off and put it back on. It has to be laundered properly after it's been moist. So switch out to a dry, clean, dry mask if there's any moisture built up, okay? And only use the mask again after it's been properly laundered. Okay, next slide. The other thing, just to go back for a second, the other thing about putting on a mask is that it can provide a false sense of security, like, oh, I have a mask on, so I don't have to worry about all these other things. And that's one of the dangers of these cloth masks, is that people think they get overconfident that all the other things don't matter. And all the other things actually matter more than ever, which is the hand washing and all the other things you people already know. So bottom line is the protective, ability of mask is created through the combined effect of transmission blocking, which is the filtration and the fabric of the material, the fit and the related air leakage related to the fit, and the degree of adherence to proper wearing and disposal of the mask. So those three things together, the fit, filtration, and I say following the rules, which is hardly something you ever hear from me, but that is the critical three things that make a difference in whether any mask is going to work for you, including the N95s. If you have an N95 on and it's not sitting on your face properly and you've lost the fit, you are not protected with that mask either. It's fit, fit, fit. Okay, next slide. Okay, so here's our synthesis tables to back up everything we've told you. So here's our levels of evidence on, Inga and I reviewed quite a bit of literature. It goes way, way back. I mean, people were looking at masks back in, the early 70s up until, very current. So this is these were our keepers related specifically to this topic, but there actually was a good deal of literature out there sort of related to, kind of peripheral to this, but this is, so we did our homework. And then the next slide is a synthesis table that supports, whether or not you should wear them, and yes, no, and the reasons why yes during a pandemic, and the reasons are listed below in the legend. So hopefully this is, next slide, Bindu. This is helpful because there's a lot of controversy out there, and a lot of people, like we hear from people all the time, and we just heard in the AONL webinar that communities are trying to rise up and help, and so these cloth masks are a massive thing that people are doing and creating, and so using them properly and making the most out of them is something that I think is really important, even on the inside of for the healthcare workers. So what, I don't know what's happening with the masks. We got to go back. Okay, so I'm going to turn it over to Dr. Zavinskis, Inga, and she's going to give you the mask message related to consumers.
Next slide, Vindu. Thank you. Good afternoon, consumers. Thank you so much for joining us. My name is Inga Zavinskis. I serve as the Assistant Director of the Consumer Corps. Many of you have been reaching out to us with questions about your homemade cloth face masks. Just to reiterate what Lynn has stated, wearing a homemade cloth face mask does not provide complete protection. So even when you wear one and you're out in public, please be sure to abide by the other ways to protect yourself and prevent infection. Next slide. So specifically, what we want you to focus on is trying to stay home. And the reason for that is when you stay home, you're less likely to be exposed to the coronavirus when you're out in public. And also what we're discovering is people tend to be asymptomatic. They may be harboring the virus and they feel great one day, they go out to the store the next day, and then subsequently they become ill. So unknowingly, they've exposed people to the coronavirus. So stay home to avoid getting exposed to it yourself and also to prevent the spread of the coronavirus without you even knowing it. The other thing we strongly recommend, of course, is washing your hands. We know that this is really one of the best ways to protect yourself and your family. So be sure to continue with your great hand washing at home. Next slide. So that being said, we recognize that sometimes you do have to go out in public. You need to go to the grocery store, you need to go to the pharmacy, you might have to get some blood work done at the doctor's office. So we took a look at the science for you about how to make a homemade cloth mask work better based on science. And we came up with a checklist for you to help you when using this at home. So once again, we can't reiterate enough about washing your hands before putting on and taking off. You basically need to assume that the outside of that mask is contaminated. So when you go to take it off, try to handle it by the sides, by the straps, remove it and discard it. And if you're going to rewash it, but place it somewhere separately. And then immediately wash those hands because they are contaminated. Consider them contaminated. Even though you're wearing the homemade cloth mask, you still want to distance yourself physically from people. Remember the 6 feet rule. When you design a homemade mask, design purposefully. Put some thought into it. So what do we mean by that? Select a fabric that is soft and stretchy and has a tight weave. And part of why we say that is a mask doesn't do you any good if you don't wear it. So it has to be comfortable, it has to be tolerable. And we talk about tight weave, maybe some of you have seen this, but they talk about placing the fabric up to a light and seeing how much light goes through it. And if you have a tight weave, less light will be able to penetrate through the fabric. So try to select a fabric with a tight weave. As Lynn already said, when that homemade cloth mask gets damp, please remove it because that moisture will affect how well that mask filters out particles. And lastly, we came across a really interesting item from the evidence that considered for you to consider using pantyhose, basically taking an old pair of pantyhose, cutting it on either side, so you end up with the tube, and pulling that over your head to provide an additional layer. And what that does is that will make that mask fit tighter to your face, and it also adds another layer of protection. So that's something we found from the evidence. All of these recommendations are based on science. You'll notice the link at the bottom of your page. If you'd like the references, that's where you'll want to go to find those. Next slide, Bindu. That being said, we recognize some of you are asking us about fabric. What we do want to tell you is that research results vary. So even the scientists are having a little bit of conflicting information about this, but we want to present this information to you objectively. So there was one team of researchers that recommended using a Hanes sweatshirt material to make a homemade mask. A couple other groups recommended using a tea towel. And yet another group of researchers recommended a cotton blend t-shirt. So any of these type of fabrics have been studied in the literature. What we want to stress to you is rather than focusing on the type of fabric that you select, instead focus on the fit. How well does that particular fabric fit your face? Is it stretchy? Can you make it snug around your face? That's really more important than the fabric selection. Next slide. So some design recommendations. As I just said, try to make that mask fit snugly around your nose and mouth. You don't want any air gaps. You don't want air coming in around your nose or the sides, and you don't want your exhalation particles going out. The other thing that we found in the literature is support for creating a cone shape or a tetrahedral shaped pattern. And interestingly, Shakya found that that filtered more air pollution particles. Now, that being said, understandably, right now we're dealing with the virus, not necessarily air pollution. But nonetheless, we felt that that was an important evidence-based recommendation for you. The bottom line is, remember that any mask is better when the seal on the face is good. So it's really about fit. Next slide. That being said, we understand that some of you will want to make a rectangular shaped mask. It's easier to sew, it's easier to create. As Lynn already said, believe it or not, some of this was already studied back in the 70s. So if you're going to make a rectangular shaped mask at home, make one with pleats. And the reason why is that improves the filtration efficiency. It adds a few additional layers of fabric on that mask. It's going to provide a little bit more protection against those particles. And once again, you'll want to make sure that that mask extends far back over the cheeks and well underneath the chin. And again, to try to cover as much of your face as possible. And that's to give you additional protection. Next slide. I'd now like to introduce our next group that's going to talk to you about ventilator sharing.
Hi, I'm Dr. Jennifer Dean, and I'm going to start the topic of ventilators. Not only multiple patients to one ventilator, but also triaging patients in the center or in the setting of scarce resources. Next slide. So multiple patients to one ventilator. Overall, this has not been studied in humans. This has only been studied in either the simulation setting or with adult human-sized sheep. In both of these studies, the ventilators were used on multiple lungs for a maximum of 12 hours. Some of the concerns, the first one is microbial cross-contamination. The theory is that the circuit on the ventilator is a closed system so that this would not happen, however, it's not been tested. The other thought is that all of the patients would have the same infection with the COVID-19 virus, so does this really matter? The next concern is lung compliance. In a diagnosis like ARDS, or acute respiratory distress syndrome, the patients have a decreased lung compliance. Basically, this means that there are different settings that you need to make on the ventilator to ensure that the patient is receiving the appropriate oxygenation and ventilation. The recommendation by the previous researchers to overcome the differences that you may see in this is to assign patients to groups based on their lung compliance. So this would be something to take into consideration if you were putting multiple patients on one ventilator. The next concern is PEEP, or positive end expiratory pressure. The study that used the 4 adult sheep only used a minimal PEEP setting of 5. And in ARDS, there are often much higher requirements to allow for appropriate oxygenation. And whether or not you set the PEEP higher, would it be delivered to all of the 4 patients or 2 patients equally is a concern. And finally, tidal volume. This is a setting on the ventilator that is based on one's ideal body weight. So what you would have to do is you would have to make sure that every patient that was being hooked up to the same circuit have the same ideal body weight and thus get the same tidal volume. Overall, given the limited research behind placing multiple patients to one ventilator, proceed with caution and continue to look for data that is coming out about COVID-19 and for those who are using this method currently. And Penny Gorsuch is going to continue.
So, hi, I'm Dr. Gorsuch. Thanks, Jen. So, based on the lack of evidence, as Jen just alluded to, a consensus statement on multiple patients per ventilator was written and published on March the 26th, 2020. And as you can see, it was a consensus statement from multiple critical care experts in the field of physicians and nurses, and also in pulmonary, which issued this consensus statement for the concept of placing multiple patients on a single ventilator. And basically, these clinicians are not recommending it at this time because it cannot be safely done with the current equipment. And the physiology of the patients that have acute onset respiratory distress syndrome is very complex, even when they do not have the COVID-19, that is complicating it even further. In ideal circumstances, ventilating a single patient with ARDS is very difficult and is associated with a 40 to 60% mortality rate. So we have included here for your reference the consensus statement that you can assess on our website. Next slide. So based on the lack of evidence of putting multiple patients on a ventilator, we looked at what else was out in the literature. And we found a study by Dr. Eric Wilkins and Dr. Gary Klein that was written in 2010 post-Katrina. And these two physicians contacted all 50 state public health authorities and examined their emergency preparedness response plans for a pandemic. And what they found was only 9 states actually included a plan for mechanical ventilation triage. All the states relied on the CDC's flu surge plans, and there was a lack of consistent estimations of even what our ventilator capacity was. So these authors, based on this lack of evidence, developed guidelines for mechanical ventilators and the implementation of an agility score, which they based their evidence set forth by the U.S. Department of Homeland Security and a triage article previously written by Hicks and Laughlin in 2006 to use in the event of a pandemic. So they developed the agility scoring system, which is a recommended guidelines for framers of federal, state, and local institutions to look at medical resources when allocating their plans, as according to use of mechanical ventilators. Next slide. So these authors suggest that states and emergency planners incorporate these guidelines in planning for a disaster to ensure an equitable, transparent method to triage mechanical ventilation when the time comes in response to a disaster like a pandemic. This scoring system increases the likelihood that patients whom mechanical ventilation would benefit actually will receive this critical resource. The agility scoring system is meant for use in a disaster and to be used in only extreme circumstances like some of you may find yourself in now, where this scoring system can also actually serve as a medical record and does not require extensive time to complete. The agility scoring system is an additional tool to help in a pandemic crisis, to help clinicians make those difficult decisions that may have to be made. Next slide. So in addition to the agility's scoring system, which for triaging, there is also a very frequently used scoring system in intensive care units called the Sequential Sepsis-Related Organ Failure Assessment, or the SOFA score. This SOFA score was developed back in the 90s, and it originally started just for sepsis-related organ failure. But what they found is that it could also be applied to other critically ill patients. So in our review of the literature, we had 2 systematic reviews. And in our first systematic review, there was 87 RCTs. And in the second systematic review, we had 18 RCTs. And these, we had additional RCTs, cohort studies, and prospective observational cohort studies. And basically, this tool, the SOFA score, is an assessment score that can actually provide you with a predictor of mortality in an intensive care unit setting. And the 2 things that we found that was in all the literature, that the change in the SOFA score is a greater predictor of mortality than that fixed SOFA score. And so as a previous ICU nurse, I know we like to watch our trends. And so trending that change in SOFA score is a greater predictor. Now the literature was mixed on the time frame of the change of the SOFA score. Some articles had 48 hours, some had 120 hours, and even some said the change at 7 days was a greater marker of mortality or predictor of mortality. And so you're looking for a SOFA score of greater than 2. And in COVID-related patients, we did find that an elevated SOFA, advanced age, and a D-dimer were identified with a poor prognosis. And like many of you, you're keeping up with the current literature, and other approaches are coming out daily. So there has been op-eds from New York, from physicians from Germany, from all over the country. So you really do have to stay up with what's coming, out in the literature on this topic.
The criteria for screening and triaging appropriate alternative care, or CRYSTAL, was created to help identify the elderly who were admitted through the emergency department who may be at the end of life and benefit from end-of-life care as opposed to aggressive management. It was not intended to lead to withholding care from individuals, but it may be a beneficial tool during this pandemic to allow healthcare providers to initiate conversations with patients and families earlier about end-of-life versus aggressive care, especially if resources become scarce. The tool is easy to use, and these are some of the components. A plus is that as far as lab values, you would only need a urinalysis to assess for proteinuria and a blood glucose. There is also a separate tool that is meant for those who are inpatient when a rapid response has been called. Next slide. The framework for allocation of mechanical ventilation in disasters takes into account both the likelihood for short-term and long-term survival. Short-term is based off the previously discussed SOFA score for adults and the PLOD2 in pediatrics, and long-term is based off comorbidities. The comorbidities that are assessed are those that, if present, are so severe that the patient would likely not survive the next 12 months, even if successfully receiving care in the critical care setting. Additional considerations include those who are pregnant and require mechanical ventilation. If there is a tie, then the life stage can be considered. A first-come, first-served basis or a lottery system can be used. You can see at the bottom how the life cycle consideration is taken into account. Finally, there are excluding factors such as an unwitnessed, recurrent, or unresponsive to defibrillation cardiac arrest, or advanced and irreversible neurologic events. Next slide.
Unfortunately, there is limited evidence available related to mechanical ventilation triage protocols in the pediatric population. A review of the literature has demonstrated the availability of two different types of tools that can be integrated with clinical expertise to inform clinical decision-making and mitigate clinician emotional burden regarding to the allocation of mechanical ventilation and other healthcare resources in disaster situations. Next slide. The Agilities tool, which Penny discussed earlier, does not have an age limitation and therefore can also be implemented in the pediatric population. The ease of use, lack of extensive laboratory tests, and the ability to be applied throughout the course of the patient admission makes the Agilities tool an appropriate tool to determine the best use of scarce resources in the pediatric population, in addition to the adult population in a crisis situation. Next slide, please. Tools similar to the SOFA score have been developed in the pediatric population to predict mortality risk in the pediatric intensive care unit setting. However, none of these tools have been validated for triage. Some state disaster plans have adopted one of these mortality risk assessment tools. The tools may assist clinicians in recognizing the most appropriate and or effective use of healthcare resources, such as ventilators. However, assessing for high risk of mortality alone in the pediatric population will not have a big impact on resource allocation because pediatric mortality rates are relatively low compared to the adults. In order to calculate any of the validated pediatric mortality risk scores, multiple laboratory values must be performed, which requires both time and resources. The PLOD2, PRIM3, and PRISM3 are all up-to-date validated pediatric mortality risk assessment tools that have been shown to be good to fit in multiple cohort studies. Unless one of these tools is already used within an organization, the evidence-based recommendation is to utilize the PLOD2 for a crisis situation. The PLOD2 has the ability to be applied throughout the course of the patient admission, unlike the other two tools which calculate mortality risk only at admission, and is available in the public domain. Next slide, please. Here's a snapshot of the PLOD2. It assesses neurologic, cardiovascular, respiratory, renal, and hematological factors. As you may be able to see in the picture, some of the cutoff points for the score are age-based. The score ranges from 0 to 33. Different ranges of scores have been assigned to different ventilation priority levels within multiple state ventilator triage plans. Therefore, further research is required to determine the best priority categorization. I am now going to pass the microphone over to Dr. Molly McNett and Dr. Linda Connor.
Thanks, Laura. Hi, my name's Linda Connor, and we're going to be talking, Molly and I will be talking about the staffing ratios in ICUs. Next slide. There's quite a bit of literature about staffing ratios and patient acuity, and many researchers have studied the impact of these on different staffing models, on patients and clinicians and organizational outcomes. But all of these studies have been done primarily under normal conditions. So based on the review of the literature, what we know is that there's no single widespread solution to nurse staffing in the intensive care unit. This is, as a result of the wide range of patient acuity, as well as the availability of the interdisciplinary staff, and also the patient's needs change very frequently in the intensive care unit. And there are some states that have mandated staffing ratios, and a common ratio that's most reported is that it's either 1-to-1 or 2-to-1, meaning 1 nurse to 1 patient or 1 nurse to 2 patients. And there's lots of different staffing models that exist, but the model is going to have to be customized to the institution that you work at. And that's going to be based on your resources, and who is in charge of the ICUs, whether it be an intensivist or anesthesiologist, what role the nurse practitioner, what role the physician's assistant, respiratory therapist, and nurses are assigned to in your hospital. And again, these models work really well in normal situations. Next slide, please. There really are no evidence-based models for ICU staffings during pandemics. And even these models that we use may not even be applicable or feasible during a pandemic or a disaster or a crisis. So we must rely on the evidence that already exists, which is based on previous pandemics and at the expert opinion and observational level. So all current evidence related to pandemics, disasters, and crisis are mainly expert opinion. Next slide, please. And this slide is showing the synthesis table for ICU staffing during the pandemic, disasters, and crisis. And next slide, please. And based on this level of evidence, the following are what we are recommending. First of all, you need to implement a care team model that works for your organization and your ICUs. You also want to expand clinicians' expertise. You also want to use a tiered staffing strategy, and Dr. McNett will talk about this next. And some things that you've probably already have done have been to limit routine services, all elective surgeries be canceled. You want to curtail administrative as well as teaching responsibility of clinicians. You may need to cancel staff vacation and staff's leaves. And reassigning staff is going to be super important. And when you do this reassigning of staff, it's going to be important to provide them with training and just in time training for what they're going to be needed for. Next slide. And I'll turn it over to Dr. McNett.
All right, thank you, Linda. So oftentimes the question arises, what does a team healthcare delivery model or a tiered staffing strategy actually look like in the time of a pandemic? And while there's no evidence-based recommendations, as Linda mentioned, there are some expert opinions that have been proposed by consensus teams based on information that we have about what works from prior pandemics that can be modified to put forth some proposed strategies that are specific for this pandemic. So one such example of what that care model or a tiered staffing strategy would look like that's specific to the COVID-19 pandemic is provided here in front of you. It's proposed by the Society for Critical Care Medicine, and I would refer you to their website. It is available for free, along with a very in-depth description of the different components of the model and the data that this model was based on. So this model actually was originally adapted. The original model was from the Ontario Health Plan, and it was a proposed model for general influenza pandemic outbreak. So the Society for Critical Care Medicine utilized that model, modified it based on what we're seeing currently with the COVID-19 pandemic, and then also integrated data that we have from the American Hospital Association in terms of what the resource availability here in the United States is in terms of number of beds, and then also number of trained intensivists to deliver the care that's needed for those COVID-19 patients that are critically ill, as well as number of advanced practice providers who were trained in critical care in the United States, and certainly numbers of ICU trained nurses. So using the tiered staffing strategy that you see in front of you, the individuals listed in green are those members of the healthcare team that have that specific critical care training that may be needed, particularly in a surge situation that we are starting to see in certain areas with the COVID-19 pandemic. Those especially trained individuals are then supplemented and supported by non-ICU trained members of the healthcare team who may be physicians who are typically attending physicians, but may have had a little bit of ICU training or exposure in the past. Certainly CRNAs, respiratory therapists, or physicians who have some training or expertise in how to appropriately manage mechanical ventilation and airway management is critically important. And then also reallocating other staff, including nurses, but all members of the healthcare team. A great example of that is members of nurses on surgical floors, PACU nurses, members of surgical teams who may have decreased volumes right now due to canceling of elective surgeries, but providing some of that just-in-time training to have them support those critical care teams. They wouldn't necessarily be expected to be, delivering the critical care for those COVID-19 patients. In some situations that might have to happen depending on the surge and the local resources, but even just helping to support the ICU patients that are presenting who aren't necessarily COVID-19 positive, but still require that high level of critical care. And being able to train these supplemental staff in how to provide some general nursing care while those with a critical care experience are really providing some of those higher level interventions that are needed. So again, I refer you to the SCCM website for a detailed description of what this might look like. This is just one example. Certainly it would need to be modified based on your local resources and then also the amount of surge that your facility is experiencing. There's also available for free on the SCCM website training materials for non-ICU staff that if you're in a situation where you're looking at reallocating some staff to help support some of the critical care needs, there are free training resources available on their site as well that would be very helpful for a lot of sites as you're looking to modify staffing. Next slide, please. So when you're looking at any staffing situation in the midst of a pandemic, certainly there's critical pieces that you need to consider. Those include the treater, the time, the treatment, and the threat. So certainly in this situation, we're really seeing an increased need in the people who have critical care training, the amount of their staff expertise, the time, the amount of time that's required to dedicate the care for the high level that those patients need. Treatment includes the amount of resources required to manage those patients. Specifically in this COVID-19 pandemic, certainly we're seeing the resources including the correct PPE that needs to be used and ventilators among some sites as well. And then certainly considerations regarding threat need to be incorporated into any staffing decisions that are being made as well. Certainly, again, one that we're seeing quite often with the COVID-19 pandemic is exposure threats to staff, PPE changes, imminent dangers, not only to providers, patients, but also family members and other patients that might be there but might not be COVID-19 positive currently. Next slide. So here's a synthesis of some of the other additional evidence that we found that are specific towards strategies that can be done when you are looking to support your staff during a pandemic. So a summary, again, is provided from those professional organizations and expert opinion type recommendations, and some of the specific strategies that are listed there specifically to support staff are provided. Next slide. So specific strategies to support staff during the pandemic include, whenever available, providing some type of child care support for staff. We've heard lots of innovative suggestions from that are currently being done from healthcare organizations across the US. We have some centers having staff that have been reallocated due to the surge. So, research coordinators or medical students who aren't allowed right now to provide direct care, but mobilizing and providing in-home child care support for hospital staff who will have to go in. So we've seen some really innovative partnerships happen there. Providing on-site respite, including food and a quiet place for staff who are treating those patients and dealing with the midst of a surge to find a quiet space in between shifts. Providing on-site housing, again, we've seen a lot of innovative approaches to this, transferring, some college dorm sites if they're near academic medical center into temporary housing for frontline staff, converting hotels that are near hospitals as well for no-cost housing for staff in between shifts to not only provide, again, respite for them, but to provide element of safety for their family members as well. Certainly varying lengths of shifts, providing some transportation to and from the hospital are other strategies as well. And perhaps the only one of the positive things, if you can ever say there's a positive thing in a pandemic, is that it tends to occur a little bit more slowly over time. So hospitals, depending again on geographical location, may have some time to plan in advance for some of these staffing alternatives. And we see many hospitals around the world actually utilizing information that we have from other sites and planning accordingly in terms of staffing. Next slide. And then I do just want to highlight some of the innovative solutions that we're seeing from the field right now from nurses. There was an article published just last week in the Journal of Neuroscience Nursing, and it was observations and innovations from the field from a team of nurses down at University of Texas Southwest. They have been extremely innovative in terms of how they're modeling their nursing care in providing critical care to COVID positive patients within their organization. And really they base it on three key premises, which is to reduce unnecessary use of PPE for these patients, promoting staff safety and readiness, and reducing foot traffic. And while they have a number of innovative solutions that they have proposed, and again, I would refer you to the article, they do have a very comprehensive listing of innovative strategies that really are applicable to many critical care settings. The ones that we have listed here really address all three of those key premises. So they include certainly adjusting your staffing ratios. Isolation patients are certainly one-to-one, utilizing a runner, so a nurse who's not assigned to that actual COVID positive patient, but is designated to support either 2 or 3 other nurses, get them what they need so they don't have to constantly be removing PPE and reapplying PPE just to get supplies, but they have a designated runner who can do that. Methods for them to communicate while they're inside the room to individuals outside of the room, certainly clustering activities, any kind of video monitoring, or they even have in ICUs where they have the glass doors, the dry erase markers, and they're able to write notes on the glass doors to communicate to team members outside of the room what's happening inside of the room. And then certainly utilizing a team approach to consolidate care whenever possible. They also include in the article some great photos of other modifications they've made, which include getting IV pumps out of the room, ventilator control panels out of the room whenever possible, again, to try to limit those number of times that the nurses have to enter the room, but it still provide that level of care that the patient requires. So again, I refer you to that article. It's actually available for free right now on the Journal of Neuroscience Nursing webpage, and it's a great resource just with some innovative solutions that are currently being done from teams of nurses down in Texas. And with that, next slide, and I will turn it back to Lynn to give us some concluding comments before we open it up for questions.
Okay, well, thank you to my fabulous Fuld colleagues. It's just been, it's an intense time for everybody, and we, we as a evidence-based place, hub, we believe that evidence is especially powerful in a time like this, and we hope that putting these resources together help you make best decisions, even in times like these. Evidence can really serve to help you make best decisions. And that's where we are hoping that we can be of service to all of you. You can see on the picture here, there's more than just the people that you've talked to today. The Fuld is a robust and wonderful group, and we want to be of service to you in this time. So keep the channels of communication open with us. Let us know what you're struggling with. I want to, save time to get to the questions that we have from today, but some of you are already, communicating with us on a regular basis just through email, like help us with this, help us with that, and we are happy to hear from all of you and to do what we can to help those of you who are doing this amazing frontline work. Before we open it up to questions, which I'm happy to do, I just wanted to, I was listening to the AONL had a webinar on just before ours, and it was about staffing. And it was 3 nurse leaders from hospitals in New York talking about like what is actually happening. So I wanted to piggyback onto something that Molly and Linda were just talking about with staffing. And they had implemented at 2 of the hospitals this team nursing strategy based on the evidence, I hope. But anyway, one of the comments from one of the nurse leaders where they had implemented team nursing was, it's a very new concept to a lot of younger nurses. Some of them are not old enough to have lived through the years of what is team nursing, so it's a completely new concept. So expect a little bit of a learning curve on that from your younger nurses, that when you say we're going to implement team nursing, they're like, I don't know what that is. So it was just an interesting current anecdotal piece that I wanted to throw into the fact that it's a great idea, but it may not be something that everybody knows how to do. So anyway, so Bindu, you're going to help us open up to questions. So we'll all put on our mics and be able to answer. When I was watching as we got started, so I just want to try to pick up on a couple of the mask questions that I saw popping up. So the question is coming, many questions are coming up as to what else can I stick in this mask to add more layers. People are putting in coffee filters and furnace filters and, kitchen sponges, you name it, people are, putting it on their face. So, excuse me, in the literature, we, and Inga, can jump in here, we did not find any literature where these things had been tested specifically, furnace filters and coffee filters and all these things. There was no literature that said, coffee filter is better than a furnace filter. Just doesn't exist, at all. So the only thing I can say is, the filtration, the amount of filtration is one of the key components of how well a mask works. So if you're going to make a cloth mask and you're going to make it out of 2 pieces of cloth and you want to slip a coffee filter in there, I can't imagine it's a bad idea because it's another layer. The tricky part becomes, when do you put so much filtration into that mask that it becomes a problem to breathe? And so for people who have asthma, or what, even without asthma, if you make the mask so thick and so impenetrable to particles, it also is impenetrable to breathing. So it's trying to find that balance. So I'm pretty, so more layers, more filtration, the better. But there is no literature out there. And Inga, you can jump in here, that compared different kinds of household filters and whether they work better.
Yes, Helene, I agree. We did not see anything specifically about coffee filter or furnace filter. There is a study by Davies. It will be back on our website. They did look at a vacuum cleaner bag, so if you're interested in that. But I would agree with Lynn that the issue is you have to find that balance, that yes, the more layers you add, but it has to be comfortable and you have to be able to wear it. So that's the only thing that I've seen, the vacuum cleaner bag. But I refer you back to Davies, to that study, and I'm happy to share that. It was published in 2013. It's on our website.
And Bindu, I see you crossing out. Have you found any evidence to support or refute cloth covers over the N95? I would say no. Again, not specifically. And again, it kind of the same answer, which is, they are made with a certain amount of filtration combined with their dependence on fit. So adding another layer to an N95, again, you know, it follows the same idea of the more layers, the better. But if it impacts the fit by adding, you know, clunking, you know, as you kind of throw more and more things on your face too, it can start to decrease your ability to make all of that fit. And, you know, my impression from the literature, quite frankly, was fit is a huge, huge big deal. And the thing people don't think about, they think they slap something in front of their face and then, whoo, I'm good to go. And that is not the case. So try to find that balance of putting so many things over your face that either you can't breathe anymore at all, and or you've made it so clunky that you can't secure it well. I wanted to make sure we got to the point. We had a respiratory therapist who jumped in here who had the point about it, the sharing a ventilator being unsafe. And so I wanted our group to loop back to that. And I'm pretty sure that's what we're saying. That's why we moved towards telling you more about triage. So I want to make that very clear that the literature is not supporting putting more than one patient on a vent. So we agree with you. And so
yes.
we shifted our focus to, because that's not a good idea. How do you use the ventilators in the best triage, scientifically based ways? So I just wanted to, you guys can jump in on that.
So hopefully if you're using a triage system, the hope would be that you don't get to the point where you run out of resources and come to having to put multiple patients to one ventilator. And the literature is not there to support multiple patients to one vent.
And all of those tools that we suggested, the agilities tool, it will be on our website. There are no, we could not find, I guess I should caveat that, of anybody that's used the agilities, but remember it was done after Katrina, and this is our real first, in this country anyway, mass event, pandemic or catastrophic disaster we've had since then. So that's why we put that out there for you in our references.
We have a ton of other questions coming through. So I'd like to start at the beginning. Have we already addressed the PUI in hallways question? Who can take that on?
We did not specifically look at that, no. And in terms of showering facilities, again, we didn't look at this as a question. So it's one of those things we can put on our list of, you know, sort of decontamination. But the things that, so I don't think any of us have an answer for that first question because we didn't look at those things specifically.
Any information on the P100 respirators?
Not that I recall seeing anything on P100, 100 respirators, not in the literature, no. Didn't see it anywhere.
I'm gonna skip this one because it's about face shields and PUIs again.
Okay, hold on, go back up there. That one right there, healthcare workers are reusing the surgical masks until they're grossly contaminated for up to a week, if able. And they have to wear them between patients. Face shields are additional for PUI or COVID plus patients. So those masks are filthy within a few hours. So that's bad practice. Grossly contaminated masks and wear them for a week. You know, based on the literature and everything we know, you know, sort of all know anyway, is that would be, you know, I don't, is that because there just are not enough masks and it's either wear a grossly contaminated mask or wear nothing? So I think there's some context to that question perhaps. Reusing masks, there is some emerging literature about, or emerging talk about ways to decontaminate masks. And so actually Battelle here in Ohio, they've established a very, you know, robust way of decontaminating masks. They're decontaminating masks at like 160,000 of them a day here in Ohio. So, but I think those are the N95s. I don't think they're decontaminating paper surgical masks. So wearing a grossly contaminated or wet or mask is obviously, but it is clearly not in the literature at all. It is a bad practice. Keep going. Okay, so staffing question is next.
Yeah, I can weigh in on this question here. And during surge, you want to reassign staff. You can take nurses maybe that are working in the PACU and retrain them to work in the ICUs. You can take nurses from step-down units and move them into the ICU. But training is, just-in-time training is going to be really critical. So when you're talking about the nurse educators, the researchers, others who are not in direct care roles, absolutely, and the thing about a pandemic is that we have time to prepare for this. So we should be incorporating all of these ways to increase staffing demands before, the surge arrives. So any way that we can bring in more staff or get more staff trained to care for patients that will be on ventilators, that's the direction you're going in. And also I've heard that nursing state boards are kind of reaching out to nurses newly retired that might be able to come back into the workforce. So that training is going to be a real critical part of this surge preparation for staffing.
Just on this, again, I was just listening to the AONL webinar before this one, and these are people who are in the, mid-surge in New York from the city. And what they were kind of doing was like a backwards kind of triaging, like, not like people previously in administrative roles were going into this role, and then this, step down unit nurses going into ICU, med surge units going into PCU, ambulatory nurses going into med surge, and administrative role people going into ambulatory. So sort of flipping that, and everybody's cross training to the next higher level of care rather than taking somebody who hasn't, been at the bedside in a long time and throwing them into the ICU. So they were, what we heard, and training is a big deal. So educators are being taxed, big time. But so that was their sort of methodological approach. That it was like almost like a triaged reemployment or deployment back into practice. What else? We are converting at the bottom. We are converting a PACU unit into an ICU. We are planning to keep nurses in PPE for the entire 12-hour shift and not allow staff to leave the unit. Any suggestions? So go ahead, Molly.
Sure. So, as we highlighted with those strategies to support staff, there has to be a location of respite for those people. You cannot expect people to go 12 hours and not use the bathroom, not eat or drink. Certainly that will make them more susceptible and more vulnerable to illness themselves, and certainly burnout and other mental and emotional well-being, health considerations. So a potential strategy there would be designating some part of the PACU for respite area for those individuals. Certainly, we can appreciate the concern for not wanting them to be going in and out of the unit, but at least allocating somewhere on that unit as a respite location for them to once they've removed their gear, they can, use the bathroom, have something to eat, and have some type of respite or short break. There's also been reports, certainly it would be ideal if you have a negative pressure room with the ante-room for donning and doffing before going into the negative pressure. But realizing in these situations, you might not always have an ante-room attached to that ICU area. And so creating kind of a marked off ante-room, the article that I had referenced in there actually provided pictures of this. They actually used tape on the floor to designate kind of where a donning and doffing area could be outside of a room if you don't have an ante-room. So maybe designating a specific space for, applying or removing PPE prior to entering that designated area for respite care. But really, there is a multitude of literature on clinician well-being that's out there that can support the fact that the staff need some type of respite to prevent burnout during this time.
And also on the AONL webinar that they had earlier today, they were talking about facility modifications where they were putting up temporary walls and they were adding negative pressure rooms. So those are facility modifications. They're also talked a little bit about equipment modifications and turning some of their BiPAP equipment into respirators.
So I'm going back to the mask again because I see another comment. Reuse of the mask as long as possible might be bad practice, but we have no additional supply. So here's what I would say. I'm not saying you can't reuse them, but what I'm saying is, we do have some evidence that talks about what the condition of the mask should be. So if it gets contaminated, if it gets wet, if it's not, on your face properly, these are all things that make them less effective. So is it possible that each nurse could at least, or each clinician could at least have two so they could switch them out and, be at least for the moisture part and, the ability to take off the grossly, contaminated one. And, there are things that people are doing for decontamination. So I understand that, the supplies are limited or, shot, but if what you're saying is you only have enough supply for every clinician to have one mask for the, the duration of this, that's it. That, well, I'm not sitting here in an ivory tower telling you, that's a bad idea. I'm just saying, if that's the situation you're in, then again, even a bad mask is better than nothing. So what we're trying to say is, how do we take the masks that we have or that we're creating? And so if you have people wearing surgical masks and they are grossly contaminated and they get one per day, I would encourage you to let people wear cloth homemade masks because they're better than a poorly fit, because the surgical masks are not a whole lot better than the cloth ones when they're basically, well made, like we've talked about. So, communities are, and again, I'm not recommending cloth masks, but when you're telling me that everybody gets one mask and it's a surgical mask, which isn't great to begin with, and they're wearing them for a week, I would venture to say that the evidence would support that being able to switch out to a well-made, well-fitted cloth mask that's dry, well-fitted, and well-made is better than wearing a grossly contaminated paper, wet mask for a week. So these are, this is sort of that mad mask triaging thing. But cloth masks are not great, but they are, I would say, and Inga, you can jump in on this too, but they would be, to me, superior to a badly contaminated wet mask, a paper mask that somebody's being asked to wear for a week.
I think the other thing to consider is the source of the wetness. If it's the wearer's expiration, what they're breathing out. There's another question about placing something over whatever mask you're wearing. And I could see that might protect against splashes and things like that and things from the environment. So I certainly could see that would add an additional layer, but I empathize. That is a very difficult situation to be in right now. And yeah, unfortunately, we do not have research studies that have studied this because it hasn't happened before. Yeah. So we're trying to make, we're trying to provide this information for all of you to make an evidence-informed decision, and we don't have the answers. We admit that, but we're trying to give you what we have right now based on the evidence.
Yeah, and I would encourage you, so we're going to make these slides available, these resources are available on our website and that sort of thing. So if you have things that are happening in your place that, are different than what this work can help you with, try to bring this work forward and have the discussion based on the evidence with the people who are making decisions in your organization that are making decisions that based on, this is the current best evidence. and it's not perfect, but it will inform your decision making. And if people are making decisions that are the opposite of this, I would encourage you to try to bring our synthesis tables forward and the resources that we have for you forward, and see if you can't, you know, have the decision makers see that you know, that what they're deciding off of whatever is probably not the best. And I don't know that what we're recommending in some of these decisions is more, you know, more costly or anything. It's just better decisions could be made. And you know, but you know, in desperate situations, people are doing the best they can, and we understand that. So like Inga said, we're just trying to bring forward the best we can.
Just wanted to let all of you know we're 10 minutes past the webinar end time.
Okay.
So if you guys want to continue to address some additional questions for another 5 minutes, we can keep the webinar room open. It's up to all of you.
I'll stay.
Or we can take these questions down and save them for, you know, ideas to address for our future topics that we will be considering.
So the other suggestion I saw on here was somebody said we should do a little video about the best way to make a mask for consumers and get it out onto social media. So we're going to get Inga out on Facebook doing doing a little jingle about making the masks the best way. So that's a great idea.
I did want to let all of you, I did put within the chat box, we do have a link to our website. We have created a one-page infographic that basically summarizes information about homemade cloth face masks for the consumer. That's already available on our website. So please go ahead and access that, and hopefully that might be enough to help you right now today.
Yeah, download it and get it out to your communities. So if they're going to, you know, because if they want to help you, let them help you with the best possible masks they can make for you. And yeah, pantyhose donations would be great. So it's just another thing that people, clean new pantyhose though, that'd be great. That's another thing people can do.
Lynn, there's another question here about a KN95 mask, and she says, please answer the question now, not later.
Okay.
So
yeah, we'll take a look. But it's something that's like we've seen in the last week. People are asking about these KN95s and the other ones, the 100s. What I can tell you is there's nothing about either of them in the literature. You know what I mean? Because we looked at from, you know, last week back, and they are not mentioned in the literature at all. So anything we would help you with on that, and we will take a look, will be what people are currently saying and, you know, putting forward. But they are not in the literature that's already been tested and studied, and, you know, that is because we looked at all of it, right, Inga? I mean, these newer masks and these things that are popping up were not in the literature. K95s.
What I can say is the K95, there was a document that published by 3M, it's on the internet, that compares the different mask types. And basically, I think this K95, the reason why it has the K, it's made in China, but there's a table that compares the filter performance. So for example, I'm looking at the K95, it's still greater than 95%. So I apologize, I don't know the specific question, you know, as far as the filtration, but it looks like it's the equivalent to the N95, but we're happy to post this where we have this. Again, it's a comparison document.
Yeah, they're brand new on the scene. So the other thing just to keep in mind is the only masks that, the only, you know, respiratory equipment that is at all required for any kind of, you know, to meet any standard is the N95s or the respirator masks. The paper, cloth, medical, surgical masks. There's no, they are, you know, they have to be of a certain grade, but there's no, you know, there's no regulation over them. And so you can have a surgical mask that's far more filtration friendly than another one just because you bought it from a different company, and it would be hard for you to figure out whether you have good ones or bad ones because they probably are not doing much of a job of telling you that. So make them fit.
Yeah, somebody on the chart said that chat said 3M has a table on the KN95.
Yes, but it's 3M, you know, so I don't know what stake they have in the game, but there's also an infographic out there on that Davies study where they have a whole grid of different fabrics and that they tested in that study. That's very helpful. So, we're posting as much of the stuff as we can, but a lot of the stuff is happening as we're speaking, and we are trying to keep up with what's current. But these masks that are showing up right now, like I said, are not in the literature at all. They haven't been compared to anything. There's no science that can help us on that. It's just what the manufacturers are telling us. So we take that with a grain of salt, and it is what it is, and we'll get it out to you. So Bindu, what's the story on these slides and get people having access to them? And I know the webinar is recorded. How can people, utilize this information?
We will have the recording available on the Fold free webinar site, and I will be following up with anybody who registered for the webinar. We know we had more than 800 people register for the webinar, and there is a limit in our platform for the number of attendees who can attend. So we'll definitely be sharing the resources with you through the website that we've created for the COVID-19 resources, and also on our Fold free webinars page. So please feel free to reach out to us at the contact-fold@osu.edu email if you have any questions about the resources or like new topics that you want our team to continue to work on and help you with. Anything else?
Yeah, we're going to try and do one of these, we usually do them monthly, but as we have more to tell you, we will, get back out to you and let you know when we're ready with more information on these other topics, and we'll do them as often as we have to or can to try to look at these other hot topics. So thank you all for attending. I hope it was helpful. Keep in touch with us.